Thank you, Chairman. In vitro models are often used to analyze acquired resistance mechanisms to drugs, and HCC820 cell, HCC406, and PC9 cells are very sensitive to EGFR TKI and often used to analyze acquired resistance mechanisms to these drugs. We have done several works using these cells, and today I'd like to focus on the HCC 827 cell story. So the story starts from this experiment. This cell line are highly sensitive to erlotinib, one of first generation EGFR TKI. However, after 6 months treatment with erlotinib, acquired resistance cells were established, and we designated as ER cells. This cell line harbored MET gene amplification and sensitive to combination of. So I summarize this schema. This cell line is highly sensitive to EGFR TKI, but the chronic treatment provides acquired resistance cells with MET amplification, and this is sensitive to combination therapy. And the other data is presented in my poster. So here I only show only results. So this cell line developed MET amplification. So we treated combination therapy of MET and erlotinib. Of course, sensitive to short time, but 9 months later, we developed acquired resistance cells. And as shown here, this cell line harbored T790M mutation and sensitive to second generation and third generation EGFR TKI. So as a next step, we treated this T790M cell line with second generation TKI. And also we developed acquired resistance cells, and the resistance mechanism was P10 downregulation and EGFR upregulation. And this cell line was sensitive to combination of ACT inhibition and this second generation. And we also developed third generation TKI resistant cells, and we obtained 2 resistant subclones. One retained T790M mutation and developed MET gene amplification. And as expected, this cell line was sensitive to a combination of third generation and MET TKI. On the other hand, this cell line lost amplified EGFR, including T790M mutation, but developed MET gene copy number gain. And interestingly, this cell line are sensitive to MET TKI monotherapy. So I will lastly show this result a little. So usually EGFR mutant lung cancer cell line is dependent on the EGFR signaling. And this is 4 cell lines and the parent with T790M, T790M plus MET, and this is MET only. However, as shown here, this MET-only cell line showed highly sensitive to crizotinib, one of MET TKI, and showed upregulated cleaved PARP showing the apoptosis. So EGFR mutant lung cancer cell addicted to EGFR changed to MET addiction. So we designated this phenomenon as oncogene swap, like an engine swap of racing cars. Conclusions as shown in the last slide. Thank you very much. And
John.
I was going to say, that's fascinating. It's actually what we think should be happening, and it's just a nice way to prove it. What still is interesting is that it is mutations that you see. Those are the amplifications, which you'd expect amplifications would be epigenetic, and a cell would be adaptive, but the mutations still do you know within your cell lines that when you did it, could there be that T790M in a very low level that then is expressed, or do you really think that they're getting mutations in it? Because mutations should be relatively random, and to be able to get the right focused ones, it seems like it would take a lot of generations to do that. So do you know that at all? I mean, in your pure first line, do you know if there could be any T790Ms that are just there at a very low level?
We checked the very high sensitivity method to analyze the T790M, but we could not detect T790M. But the other research group have identified this cell line have a very small amount of MET amplified subclone. So this cell lines often acquire MET amplification as a resistance mechanism. So this cell line has some destiny for MET. But if we inhibit MET prior to the treatment, then this becomes T790M. So maybe there will be more small amount of T790M at first, but I don't know exactly. Thank you.
Jerry.
Are you able to study, based on the mechanism of resistance, the actual virulence of the cell line once it acquires that change? So we're lucky in the clinic that T790M cells are slow. And then the other changes that take place, do you measure the pace of growth, or do you have any virulence assays in your work? Thank you.
Yes. So this is a cell line model, so we can see how fast they grow. And actually, we did not observe the difference of cell growth between the parent and the T790M MET. But another cell line, HCC406, this cell line acquired resistance via EMT, and this is a little slower than parent cells. This is some interesting phenomenon, I think. Thank you.
Thank you.
I think this is really beautiful work, showing how robust cancer cells are. And quite arguably, you know, cell line data oftentimes is problematic, but for EGFR, this looks really good. You know, this really mimics or shows, quite frankly, what we see in patients. So I think there's two ways forward, and I'll keep this brief. The first one is, you said this very nicely, there's a destiny for the cell, you know, to become MET amplified as an exit mechanism. You know, can you predict the destiny? And I'm not talking about fortune tellers, but can you actually maybe identify upfront which patients would actually have that as an exit mechanism? That would be really powerful if you could do that upfront, and I don't think anybody's working on that. And then the second thing is, you know, maybe there's a way to monitor early. I mean, along the lines of the presentation from Stanford, if we can do that in patients, this is very likely going to happen, and we are just unable to see it. And I don't know if you wanted to comment on one or the other.
Yes, thank you for question. As shown here, as I shown here, this cell line often use MET, and if I inhibit MET at first, but this cell line eventually acquire resistance using MET, and as told a little previously, this cell line has a very minor clone of MET. So identification of such minor clone may be helpful, I think. And another cell line, HCC406, that is often acquire resistance via EMT. So EMT destined one. But I don't know what is a good marker to predict the destiny, but that is very important in clinical setting, I think. Thank you.
Max had last comment, and then
yeah,
we'll move on.
I'll comment to that. So I think what you suggest is going to be possible, at least in a subset of patients. Probably not not pre first line EGFR inhibitor, where there hasn't been pressure to select for things like MET, but at progression on erlotinib, and we have data that there's a number of patients will have T790M plus something else, and that could allow for rational combo therapies. So I think for a subset of patients that actually may work and would fit very nicely with your data.
Great, thank you.
Thank you very much.